Okay, let's still stay in resuscitation as a topic, but let's talk about the alphabet. Okay, ATLS, ACLS, classically has started with A and B and C, which happens to be our easy way to remember how you start looking at resuscitation. But the military has propagated this idea that maybe we should use CABC, with the first C standing for catastrophic hemorrhage. And they've even gone a step further, and some people have talked about MARCH, which is massive hemorrhage, airway, respiratory, circulation, and hypothermia or head injury. What are you teaching your residents these days? Are they getting confused about what the alphabet really starts with?
I hope not. However, I do think that, we were certainly the mantra of A, B, C, D, E for the ATLS was used. I think in common sense, though, and in real life, we always simultaneously did things. In other words, if somebody came in to the resuscitation bay with a active hemorrhage, they would get direct pressure on that wound, first, even if there was an airway issue, it would be simultaneously done. So I'm not sure that the A of the airway is certainly important, but direct pressure on bleeding was also something that was done pretty simultaneously. And even in the ATLS teachings, and then certainly in the moulage, the initial resuscitation testing stations, that was also stressed. So I think it's direct pressure on bleeding. The M of the MARCH, it was always important. The C before A, circulation before airway, is a slightly different concept, but it still applies, and that is that if a person's breathing on their own, even if they're hypotensive, and if they're somewhat obtunded, it may be better for the patient to try to hemodynamically at least temporize them before you go to intubate them, particularly if you're going to use drugs in the intubation part of it, etomidate or insuccinylcholine and the such, because there are incidences both clinically and the literature starting to show up with these, is that the intubation itself can be quite hemodynamically compromising. And then if a marginal patient gets an airway when they were being ventilated with a good airway already and not getting intubated, that was probably premature to be done for somebody who needed to be, resuscitated. So it depends where the airway ended up. Obviously, an obstructed airway is something that requires attention basically immediately. You're not going to get anywhere with an obstructed airway. But to establish a definitive airway with intubation in a hemodynamically compromised patient sometimes should be delayed a little bit, and that concept has gone up in order to at least temporize in whatever way you can the hemodynamics of the patient.
Sounds like you're trying to make us think physiologically about our resuscitation and use some common sense and realize that ABC is just a mnemonic that we use to remind us of what we should be looking at. Is that fair?
I think that's fair. I don't want to downplay the fact we've all done it. We've all run into situations where the airway was a real problem, and you wouldn't, an airway that's penetrating or blunt neck injury, or foreign bodies, or there are times where the airway is the paramount issue, but many times you're confronted with a patient that is slightly obtunded, hypotensive, whose moving air, or at least has enough of an airway that with a little bit of supplemental oxygen or a little bit of, just a little bit of respiratory assist, that will do fine in the short run from a respiratory standpoint. But if they're initiated to intubate them and use drugs that have hemodynamic consequences, you may have to find the patient to really decompensate and even arrest in the situation as they're being intubated. So if you can temporize those, control the external bleeding, maybe give them some resuscitation fluids in the form of balanced salt solution and or blood, you may find that they'll do better than having that acute decompensation. So, yeah, common sense is important. And, you wouldn't intubate somebody with a stable airway with some squirting femoral artery across the room. So I think both of those algorithms make some sense, and in the real world are, just common sense applications in the clinical scenario.